Hi, I'm Zach Repenchek, and today we're going to be doing a quick review of the use of pressors in the emergency department. When we say pressors, we're really using a general term to describe any medication that helps to achieve the goal of increasing end organ perfusion. But pressors can be broken down into a couple of different categories. You have vasopressors, which are medications that increase perfusion by increasing vasoconstriction. Then you have inotropes, which do the same by increasing cardiac output. Furthermore, there's medications that are inopressors, that you have both vasopressor and inotropic activity. These medications differ in how much of each. So let's talk about the adrenergic system. For simplicity's sake, we're going to say that alpha adrenergic activity causes vasoconstriction and beta adrenergic activity causes cardiac output. So let's first look at the inopressors. These include norepinephrine, epinephrine, and dopamine. Norepi is more of a vasopressor, while epinephrine is more of an inotrope. But remember, as you titrate up your epi, you're going to get more vasopressor activity. Finally, dopamine is kind of a mess. Dopamine's activity really changes greatly based on the dose. Studies have shown it's not nearly as good as norepi in nearly every form of shock. So for these reasons, dopamine has pretty much been removed from our practice. So vasopressors. The first vasopressor we'll talk about is vasopressin. Vasopressin is interesting in that it doesn't work on the adrenergic system. Vasopressin is a naturally occurring endogenous hormone that stimulates the blood vessels directly to cause vasoconstriction. Phenylephrine, another type of vasopressor, works mainly on alpha adrenergic. We don't use phenylephrine that frequently in the emergency department because you can actually get a similar vasoconstriction from alpha adrenergic property just by titrating up your norepi. The situation in which we might find ourselves using phenylephrine is when you don't have central access, because phenylephrine is safe to give via peripheral IV while vasopressin is not. But for most situations in which we're looking for a second-line agent for vasoconstriction, we're going to be putting in a central line, so vasopressin is probably a better first-line agent in these situations. As far as inotropes, there's medications such as milrinone and isoproterenol, but for the purposes of this talk, we're going to focus on dobutamine. Dobutamine has primarily beta adrenergic activity, so it's really good at increasing cardiac output. That's why we frequently use it in cardiogenic shock. However, thanks to that beta activity, it may also cause vasodilation, so it potentially could worsen hypotension. Most of the time, if we're going to use dobutamine, we need to make sure that the patient has their volume status repleted, and often will already have norepi or some sort of other vasoconstrictor running prior to starting the dobutamine. So in general, if you have a patient who's in shock and you need a pressor, you're going to grab norepi. Especially in the emergency department where we frequently have undifferentiated shock, norepinephrine is going to be your best first choice in most causes of shock. So it's going to be the one you're going to go for. So let's take a second to talk about norepinephrine. We're going to start it usually between 3 and 5 mics per minute. However, it's not nearly as important, the starting dose, as the fact that you're going to titrate up aggressively. So I usually start at 5 mics per minute because it's easy to remember, but then I'm going to titrate to MAP goals. There's not a clear max dose of norepinephrine. It's probably much greater than even 100 mics per minute. But the important thing to remember in the emergency department is if you've reached 20 mics per minute on your norepi drip, it's time to consider adding a second agent. How about epinephrine? Is there ever a time we should be using epinephrine as the first choice? When we use push dose pressors, we're very comfortable with epi and mixing epi into a more dilute form. So epi is great as a first choice if you're using a pressor in a push dose format. We also know that epi-IM is a first-line agent for anaphylaxis. So epi-IV is the first-line agent in anaphylactic shock. This is because you can really use that extra beta activity that epinephrine gives you to stabilize mast cells and cause bronchodilation. For the same reason, epinephrine can be considered first-line drip in a patient who's sick with asthma. Otherwise, norepi is usually going to be the best first-line choice. So let's look at an overall approach to using pressors in the emergency department. For most scenarios, we're going to start with norepinephrine. We're going to titrate it aggressively, and when we get to 20 mics per minute, that's when we're going to consider grabbing a second agent. And let's look at 3 different scenarios and what we might choose as our second-line agent. So let's say you have a patient with a distributive shock, such as sepsis, and what you really need is a lot more vasoconstriction. Be the time to add vasopressin. Vasopressin dosing is easy. It's a 0.04 units per minute fixed dose, so it doesn't titrate. The second scenario is when you feel like the heart could be doing a little bit more to help increase your perfusion. So you want to increase some inotropy, but maybe also kind of maintain some of that vasoconstriction. In those situations, we can be adding epinephrine onto norepi. For epi dosing, consider just doing the same thing that you did for norepi. Finally, the third scenario is cardiogenic shock. In this situation, we're going to add dobutamine. But remember, before we start the dobutamine, we want to make sure we're euvolemic and that norepi is titrated up enough that we're getting adequate vasoconstrictor activity. So that's our review of pressors in the emergency department. Just remember, the goal is organ perfusion. Typically, we use a MAP equal to and greater than 65 as an indicator of adequate perfusion. But remember to compare that with clinical signs, such as the patient's mental status, their urinary output, etc. Thanks so much for watching. Let me know if you found this helpful.